I think the most important factor in our successful implementation is knowing why we wanted it, and everything else follows from the why. And it's all about patient care, patient outcomes, increased efficiency, improved antibiotic stewardship, the whole list of improvement that we made in patient care.
It was highly prioritized in our institution. This was definitely something that we had huge support from Dr. Hill, administration, pharmacy. Everybody was really pushing for this because we were anxious to get it up and going.
We have become the blood culture capital of the world.
We originally were budgeting to bring in the Accelerate Pheno this year, 2019.
We have never seen so many positive blood cultures in the last, I'd say, 6 to 9 months, maybe 10, 12 a day at times.
As it got closer to the end of the year, it was, no, we need this sooner, we need this now. So we actually were able to acquire it in December and begin all of the validation studies and whatnot.
The early stages of the Pheno system, we really got the entire team together.
We had champions in every department. It was so well supported by our whole team, from pharmacy and infectious disease administration. Everybody knew this new technology we were bringing in was going to be hugely beneficial for patient care, and they knew the potential that it had.
So the lab, the medical staff, the nursing staff, and it really was a multidisciplinary team to talk about how this would function and what process we were going to develop to move this along. And then we took this to the C-suite.
He says, I have some testing for you and it's going to be expensive.
And got the buy-in almost immediately.
And so we talked a little bit more about it, and he said, but this is some really neat stuff, and this is what it's going to be able to do for patients. He could definitely see the benefits of the early turnaround time on something that used to take days, and really to be able to get the results in 8 hours, make sure the patient's on the right medications. It would benefit both throughput and quality outcomes for patients. And so those are the two things that really probably outweigh price at that point.
So the idea was a good one. There's always how we would implement it, if there would be any disruption in the hospital, what the cost would be, those kind of variables. But as we worked through it and we had a goal and we had champions in place, the process rolled out very smoothly.
There's a lot of competing priorities all the time, and so we have to constantly rebalance. And this one, because we were in the middle of a cycle, we really had planned it to go into 19's routine capital budget. But at the end of 18, if we don't have everything spent, then we look at, okay, well, what do we have on the list for next year and how do we move it up? And so this was a high priority from a patient safety, patient care standpoint, so that allowed us to move it up earlier and accomplish purchasing it in 18.
I don't want to sound Pollyannish about this, but it really was not, it wasn't a big deal. It never was. I think whenever you go to the CFO with any sort of thing, you've got to prove its worth.
It was probably one of the more easy things to get through because you could see exactly what it was going to do for patient care.
So as soon as people heard we had it in-house, it was well, when are we going live? When are we going live?
They actually implemented it probably within 3 months, which is really record-breaking in terms of implementation from start to finish.
There are a couple things that were different with this Pheno implementation. One of them just being because it was so highly prioritized, the timeline was obviously quicker than we're used to with other things. There was a strong motivation to get it up and go live and be using it for patient care. And then the fact that it was just really brand new for us.
Everybody gets, something new. You know, what is it going to have to do to my workflow?
Some implementations are really just switching out an older analyzer for a newer version of the same thing, so you generally know what you're doing. But this was brand new, so what do we do with the results when we get them, and who's going to get the phone call, and some of those processes, because it was just brand new. So there was a different learning curve with this.
We did meet a couple of times as a group just to work through the workflow issues, to say, okay, who are we contacting? You know, the lab's calling nursing, but really pharmacy wanted to be a part of it. Infectious infection
Prevention.
they wanted to be a part of it as well, but it was like, okay, well, who's the best person? Who's here 24/7? So our pharmacy's open 24/7. So we work to train all the pharmacists so that way when they get that phone call, they can make a recommendation to the physician, make sure that they follow up, especially if something is resistant, to know, okay, this is an appropriate therapy, we need to change it. Or if we could de-escalate, having the pharmacist intervene at that point in time to make that recommendation and say, hey, look, do they really need to be on all three of these? Can we back off?
And I think everybody's a little bit different. It's not till you roll out something like this, then you're going to find where the issues may be, and I think it's going to be unique to each hospital.
The issue comes in getting that new process in and then hardwiring it. You know, that hardwire does take a little time. You can educate, see what goes on, and then try to make it easy enough that they do the steps repetitively. And this makes it very easy.
And I have to say, the Accelerate team was instrumental as well, and I think the collaboration between the two worked out really well.
I think it's always better to do what you can in person. Our space is tight. However, with this project, especially with just the magnitude of this project, having people here that, you know, when you think of stuff off the cuff, oh, I forgot to ask this, and they're right there and you can turn around and ask them. I think it was essential to have people on site.
Everything that was promised was delivered. There was a lot of clarity early on, so we knew what to expect. We knew that the workflow of the lab was not going to be disrupted. We knew that this was an instrument and a process that was easy to train on. It had to be simple, relatively simple, and reproducible. And that's what was delivered. In the beginning, there was some, well, this is what this means, and this is how we're interpreting it. Do you agree with us?
And I think we've always had positive experiences when you educate one-on-one and being able to talk with them as that patient comes along.
That went along for a while, and then you didn't have to do that at all. They kind of knew it was coming and knew the phone call, and then they would make the final determination of what antibiotic changes they would make.
It's amazing just how quickly you can get answers. Because before you'd know, okay, this is the bug, but are they on the right drug? Are they safe? Are they covered? What's going on? But now that worry window is shortened dramatically. I mean, in 7 hours, you know exactly what the bug is, what the sensitivity is, and you're able to make those adjustments. So you kind of get rid of that worry window.
I do a monthly meeting with all my leadership and managers, and this was one of their proud quality measures, that they continue to show real patient examples.
You know, you may have had someone that they were really worried about, maybe had a rapid response, went into hypertension, they drew some blood cultures, you got that result back, they got the antibiotics and they got better. So you can say, listen, this is what it was about. And this, you remember, you know, Miss Mabel, this is what this is what worked. That's why she's here coming to bring y'all brownies, you know.
If all of us have what that patient needs in mind, then we're always going to do the right thing. So.